Hello, this is Kim Burchell. I'm a neurosurgeon at the Oregon Health and Science University, and I'd like to welcome you to this discussion on the diagnosis of trigeminal neuralgia. This may seem like a straightforward topic, but I can assure you that the diagnosis of facial pain is not easy. And in fact, facial pains that come to the attention of specialists such as neurosurgeons, neurologists, otolaryngologists, and others can be quite confusing and sometimes difficult to diagnose. This discussion is based on evidence and also my over 40-year experience in treating facial pain disorders. Primary trigeminal neuralgia, that is, pain of spontaneous onset, can be divided into two types. Type 1, meaning more than 50% episodic pains, and Type 2, meaning more than 50% constant chronic pain. Secondary facial pains with specific etiologic onset include trigeminal neuropathic pain from unintentional injury to the nerve or the trigeminal system, trigeminal differentiation pain, which can occur after intentional injury to the nerve or the trigeminal system itself, symptomatic trigeminal neuralgia, secondary to multiple sclerosis, post-herpetic neuralgia, which follows ophthalmic herpes zoster outbreak or shingles, and atypical facial pain, a term which in my opinion is overused, probably psychogenic in origin, and extremely rare. When I developed the terms Type 1 and Type 2 trigeminal neuralgia, I was working on the hypothesis that trigeminal neuralgia was a continuum. My theory at that time was that trigeminal neuralgia would progressively become more of a typical neuropathic disorder, which in most instances of neuropathic pain is a constant pain. In fact, the natural history of trigeminal neuralgia puts it in a unique position in that it starts slowly, oftentimes with prolonged pain-free intervals, and that it progresses in both frequency and severity for no apparent reason, often over many years. There is, in fact, almost no other neuropathic pain condition which mimics trigeminal neuralgia. As you will see, my thinking on this has evolved. Let's turn our attention for the moment to the International Headache Society classification scheme, ICHD-3, which examines classical trigeminal neuralgia, which is purely paroxysmal. This scheme describes classical trigeminal neuralgia without persistent background facial pain. Patients are pain-free between attacks in the affected trigeminal distribution. Further, these patients usually respond, at least initially, to pharmacotherapy using, for example, carbamazepine or oxcarbazepine. While these requirements clearly define what most clinicians would describe as classical trigeminal neuralgia, the ICHD-3 goes on to describe classical trigeminal neuralgia as requiring MRI evidence of neurovascular compression. In my opinion, this classification requirement is flawed in that it mixes neuroradiological findings with the clinical description of the facial pain. The IHS classification also describes trigeminal neuralgia with concomitant continuous pain. That is termed atypical trigeminal neuralgia or trigeminal neuralgia type 2 by my classification scheme. Either of these terms invoke continuous or near continuous pain between somewhat typical attacks in the affected trigeminal distribution. However, as you will see later in this presentation, this type of pain may also be produced by another condition called temporomandibular disorder. So the question remains, does type 1 trigeminal neuralgia evolve towards more atypical trigeminal neuralgia, or TN2, over time as the neuropathy progresses? Or can more common causes of facial pain be confused with TN? I will suggest that the temporomandibular disorders can have many of the same features of TN2. I will also point out that the temporomandibular disorders are vastly more common than trigeminal neuralgia, probably by 3 orders of magnitude at least. So the question is TN2 a continuation or an evolution of TN1? In my opinion, the answer to that question is an emphatic no. When TN1 recurs, it returns in a stereotypical fashion for that patient's syndrome. That is, it returns as essentially the same pain. The one exception to that dictum might be evident in patients with trigeminal neuralgia secondary to multiple sclerosis. Those patients may have had multiple neurodestructive procedures that progressively weaken the muscles of mastication, leading to some elements of a TMJ or TMD syndrome in addition to their TN. As John Maynard Keynes and others have said, when the facts change, I change my mind. The present conclusion is that the diagnosis of atypical trigeminal neuralgia, or TN2, is likely encompassed by TMD pain syndromes, which can be confused with more classic trigeminal neuralgia. The prevalence of the TMD disorders is estimated to occur in about 5 to 12% of the population. In contrast, the incidence of trigeminal neuralgia occurs in only about 0.01% of the population each year. By these statistics, temporomandibular disorder is about 1,000 times more likely to produce facial pain than is trigeminal neuralgia. If even a minority of cases of TMD can mimic trigeminal neuralgia, then misdiagnosis will likely occur. TMD is in fact an umbrella term for several multifunctional conditions. The clinician must identify where on the continuum of TMD a patient lies. At one end of the spectrum, TMD pain can be relatively mild and resolve over time, or it may progress to severe jaw malfunction and intractable pain. It has become clear to me that at the more severe end of this continuum, patients are suffering greatly and desperate for any help they can achieve. This desperation can put pressure on clinicians to offer therapy in their own domains, potentially including surgery. Clinicians that treat facial pain need to have an understanding of the TMD syndromes and guide patients to specific therapies for these disorders. Temporomandibular disorders are often referred to as TMJ problems. In fact, the majority of TMD problems are primarily of muscular origin, with pain radiating from the temporalis, masseter, and medial pterygoid. Interarticular disorders probably make up about 1/3 of the TMD syndromes. Typical pain is in the temple, radiating around the eye, but can also radiate into the maxillary and mandibular divisions of the trigeminal nerve sensory territory. Pain is often worse with chewing and talking. Continuous background pain may not occur in patients with a more mild syndrome, but in my experience, the patients with more severe pain related to TMD have continuous background pain. One of the most confusing aspects of TMD is that bouts of severe pain are quite typical in the more advanced cases. The pattern of these episodic pains then becomes a very important aspect of the diagnosis. While the typical pains of classic trigeminal neuralgia last only seconds and usually emerge from very little in the way of background pain, patients with TMD will often have a baseline pain around 3 to 5 on the visual analog scale, with episodic pains lasting minutes to hours, sometimes days. In my opinion, it is this pattern of pain which most clearly suggests the possibility of TMD. When we examine the similarities of TN and TMD, we can see why these are so frequently confused. In both cases, pain radiates into the trigeminal nerve distribution. Episodic pain can occur in both, but in the case of TMD, that pain emerges from a background pain. Pain can be aggravated by chewing and talking in both instances, and patients may report that the pain is relieved by anticonvulsants. However, what I have observed is that in patients with TMD, the pain relief may be partial, whereas in patients with TN, The pain relief is usually quite extraordinary and often complete, at least initially. While the differentiation of TMD and TN pain can be quite daunting, in TMD, baseline pain is nearly constant, with often severe and sometimes sudden spasms of pain superimposed on this background pain. When the pains are bilateral or alternate between sides, this presents a strong argument for TMD. As mentioned, anticonvulsants can be partially effective in TMD, most likely due to the sedative effects of anticonvulsants, which are well known. While the diagnosis of TN can often be made over the phone, if you are considering the diagnosis of TMD, then the oral facial examination is a must. Tenderness of the external temporalis muscle is often found, and in addition, severe tenderness of the temporalis tendon as it inserts on the coronoid process of the mandible is often demonstrated on palpation of this tendon using intraoral examination. Bite down may be tender, but the TMJ may or may not be painful on palpation. Examination may reveal jaw deviation during opening and closing, as well as tenderness of the musculature and painful bite down. TMJ may or may not be tender, as mentioned, and that clicking and popping noises or crepitance are generally considered non-pathologic unless accompanied by pain. Thus, in my view, based on history and physical examination, trigeminal neuralgia and TMD are mostly distinct entities. Type 2 trigeminal neuralgia is most likely represented by the temporomandibular disorders. The difficulty in clinical practice arises from the fact that the TMD syndromes are far more common than trigeminal neuralgia. These TMD patients will arrive in any clinical practice that sees patients with facial pain, whether it is diagnosed or not. So the accurate diagnosis of facial pain is, of course, paramount. TMD is about 1,000 times more likely than TN and can be easily confused with TN, and often is. While TN can usually be diagnosed by listening to the patient, either by phone or telemedicine, a TMD diagnosis requires an in-person encounter and a physical examination. A TMD diagnosis needs to be strongly considered in cases of atypical TN or TN2. We have a long-standing interest in the use of machine learning to assist in the diagnosis of facial pain. As part of that process, we utilize patient questionnaires to help define individual facial pain conditions. On this questionnaire, we ask, is your pain either entirely or mostly brief, seconds to minutes, and unpredictable sensations, electrical, shocking, stabbing, or shooting? Remarkably, almost 29% of patients who were later diagnosed as TMD answered yes to that question. This points out the difficulty of using a history of episodic pain as essentially pathognomonic for the diagnosis of trigeminal neuralgia. We have done some preliminary work to develop an AI model using machine learning to help clinicians differentiate TN and TMD. This development will be presented in a separate video on this channel. In conclusion, the diagnosis of facial pain is a complex undertaking. In my experience, clinicians have little other language to describe episodic facial pain other than a diagnosis of trigeminal neuralgia. In fact, the TMDs should be a major consideration in any patient being assessed for facial pain. The TMDs probably account for the majority of atypical trigeminal neuralgia diagnoses, also including trigeminal neuralgia type 2, and the IHS classification in that regard. Neurologists, neurosurgeons, primary care doctors, and others are really not prepared to make the diagnosis of TMD since they've never been trained in this condition or in fact have ever heard of it. This is remarkable when in fact The TMDs probably represent the second most common myofascial pain in humans, second only to low back pain. We now have developed an AI model which can differentiate TN from TMD with about 90% accuracy. This model will need to be tested further in clinical practice, but may represent a major tool for clinicians. Thank you for your attention to this presentation, and I wish you well in your further care and diagnosis of patients with facial pain.